Hello and welcome back to Clinical Cases. Today we're going to be continuing to look at the foundation block, which will involve us looking at bacterial infections, sepsis, bacterial endocarditis, foodborne diseases, as well as anaphylaxis. So let's get started by looking at bacterial infections. Now there are lots of bacteria that can cause disease in humans, but one way to differentiate them is by doing a gram stain test. This will allow you to differentiate between a gram-positive and a gram-negative organism, and the way this will allow that is by gram-positive organisms will stain purple and gram-negative organisms will stain red. And the reason for the difference in colour staining is that actually gram-positive organisms have lots of peptide or glycan in their cell walls, which means they retain the crystal violet stain, which is purple, whereas gram-negative organisms have hardly any peptide or glycan at all, which means they do not retain the stain. Bacteria can also be classified in the way they look. So, for example, here this is an example of a gram-positive coccus bacteria because it is spherical in shape, and these can appear in clusters as these have here, or they can appear on their own, or they can appear as diplococci, so two together. You can also have bacillus bacteria, which appear as a long rod-shaped bacteria, and this is another way of differentiating and categorizing these bacteria. So Staphylococcus aureus or Staph aureus is a gram-positive bacteria that's very common, and it's normally found on the skin and on the interior of the nose. It's also normally found in the groin and in the back of the throat. And it's very common to take a swab before someone goes into hospital for a surgery to test to see if they've got this bacteria. And the reason they do this is because Staphylococcus aureus can be MSSA or MRSA, depending on how resistant it is to a drug called methicillin. So MRSA you'll have heard of, which is methicillin-resistant Staphylococcus aureus, and the problem with this is that it's antibiotic resistance, whereas on the other hand MSSA is sensitive to antibiotics. We can prevent Staph aureus infections through good hand hygiene and keeping all our cuts and scrapes and grazes covered, and avoid sharing personal items like towels and razors. The colonisation is more common in newborns, haemodialysis patients and patients with skin conditions such as eczema, dermatitis, and also those that suffer from diabetes. So colonisation can last from months to years, and around 30% of people on a normal day-to-day basis are colonised. But it doesn't mean that the staph has entered their system and caused an infection. The common symptoms with a staph infection include impetigo, boils, cellulitis, and any kind of staph scalding skin syndromes. E. coli is another bacteria. Now this bacteria is gram-negative, which means it appears red on the gram stain test because it doesn't retain that crystal violet staining. And again, this is a very common bacteria that's normally found in the bowel. Now, E. coli is often associated with intra-abdominal infections, but it's actually the leading cause of UTIs. So most strains of E. coli are actually good for you, and they help us with digestion, and they help us produce vitamin B12 and K, and therefore they live symbiotically with us. However, a few strains of E. coli are actually very harmful and can produce toxins, which make us very poorly. And the symptoms of these infections include diarrhea, abdominal cramping, pain and tenderness, and nausea and vomiting. So the most common way to acquire E. coli by infection is by eating contaminated food or drinking contaminated water, and it can spread from person to person, and therefore we are at risk of an outbreak of E. coli. Moving on with bacteria, so remember in terms of bacteria we treat these bacteria with antibiotics. On the other hand, viruses cannot be treated by antibiotics, and neither can fungals. So antibiotics are very specific to bacteria. So the next bacteria to look at is Streptococcus pneumoniae. So this is again a gram-positive bacteria, which you can see with the purple staining here, and the coccus shape. So again, Streptococcus pneumoniae is a common bacteria, and it's normally found in the upper respiratory tract. As you may be able to guess from the name, it is the #1 cause of pneumonia, but it is also able to cause other infections such as meningitis and other upper respiratory tract infections. Again, it's a bacteria that most people carry normally without becoming ill, and it can spread from person to person by the inhalation of respiratory droplets, and these occur through coughing and sneezing, etc. So it can be treated with antibiotics, but again we're seeing that problem with antibiotic resistance coming through, but less so in strep pneumoniae. And there is a vaccine available against strep pneumoniae which you can get at the same time as the influenza vaccine, and it's usually recommended that very young people and very old people have this vaccine. The next bacteria is group A Streptococcus pyogenes. So group A strep, we say group A because it's the most horrible, and again this is a group gram-positive bacteria. On the other hand, another good one to be aware of is group B strep, which can cause infection in newborns. Group A strep, however, we focus on because it can produce a toxin that really spreads really quickly. It can cause infection and even death. So it's quite a nasty infection, and it's normally found in the upper respiratory tract. So it's normally associated with diseases such as necrotizing fasciitis, cellulitis and pharyngitis, with pharyngitis being the most common of those, and presenting with that throat pain that comes on quickly, red and swollen tonsils, and tender lymph nodes that are in the neck. Moving on with bacteria, we can look at Pseudomonas aeruginosa. So this is a gram-negative bacteria, and actually it's fairly uncommon. It is as it's normally found in the environment, so particularly in water. So the infection with Pseudomonas aeruginosa is most commonly associated with patients who are suffering from cystic fibrosis or bronchiectasis, so those who are immunodeficient, and it usually causes chest infections in those patients. It's also good to be aware that Pseudomonas can be associated with burns and ventilator-associated pneumonia, and the reason it's associated with this ventilator-associated pneumonia is that when we use ventilators in the primary care health setting, we're actually humidifying the air that's going in, and therefore there's a risk of Pseudomonas being carried in that humidification of the gas. So, like we said, it occurs in immunocompromised patients, and those with CF are particularly susceptible to Pseudomonas. And the reason for this is that actually in CF we know that pathophysiology-wise there's a sticky mucus that builds up, and that can trap the bacteria and cause infection with Pseudomonas. Another bacteria to be aware of is Neisseria meningitidis, which is a gram-negative bacteria, and around 20% of people naturally carry this without causing any harm to them, and it's commonly found in that upper respiratory tract. It's unsurprisingly most commonly associated with meningitis, but it's also associated with septicemia. It's got a bit of a bimodal distribution in the respect that it affects people who are 3 months to 3 years old, but also those aged 18 to 23 years old as the hotspot targets for this infection. So meningitis causes symptoms such as fatigue, fever and headache, and this meningitis has been covered elsewhere in clinical cases. Having a purpuric rash that doesn't blanch is also a classical symptom of septicemia, and a good way to differentiate that septicemia has developed. Moving on, this is another disease to be really aware of. So sepsis is a life-threatening condition that arises when the body's response to infection causes injury to its own tissues and organs, and it can present with shivering, fever or colds, extreme pain and discomfort, pale and discoloured skin, sleepy or confused, and shortness of breath. Now the old classification was sepsis 2, which allowed us to use SIRS and severe sepsis as ways of measuring how progressed the septicemia was. However, now we don't use those in the new system, so sepsis 3 we no longer use SIRS and severe sepsis, but it's still good to be aware of what they are. Now SIRS is an inflammatory condition that affects the whole body, and you're said to have SIRS if you present with 2 of the following, so temperature above 38 or below 36 degrees, heart rate above 90, and a respiratory rate over 20 breaths per minute. And again, severe sepsis, it's good to know what it is. So the old definition of the severe sepsis was sepsis plus organ failure, whereas now the new sepsis definition for just sepsis is systemic inflammatory response to the presence of infection, which is infection plus organ dysfunction. So it's good to set it out clearly in your mind, the difference between sepsis 2 and sepsis 3, which is the new method of classifying sepsis and its progression, and therefore knowing what each of these terms mean, particularly in terms of what they clinically mean, so sepsis plus organ failure, sepsis plus vasopressor requirement, etc., etc. The cause of sepsis can be any infection that spreads into the bloodstream, and the main problem with sepsis is when it starts to cause organ failure, and there's a little bit about the pathophysiology here in respect of how it cuts off that oxygen and blood supply to the organs, which is what causes organ failure and dysfunction. Moving on, we will talk about bacterial endocarditis, which is an infection of the inner surface of the heart, the endocardium, usually affecting the valves. It presents with fever, a heart murmur potentially, fatigue, shortness of breath, and aching joints and muscles. And clinically, we should look for low red blood cell counts, Osler's nodes, subconjunctival hemorrhages, splinter hemorrhages, and Janeway lesions, are all indicators of bacterial endocarditis. Again, the pathophysiology is explained here. So the pathogen enters the system through the bloodstream. It forms a fibrin clot at the place of the damage. And the main problem with bacterial endocarditis is the formation of vegetations, which then break off into the circulation as peripheral emboli, and also the way it affects our valves. So risk factors for developing bacterial endocarditis include your age. So naturally, there's degenerative changes as you get older, but also being male or an IV drug user increases your risk of bacterial endocarditis. Using the BSET criteria will allow you to confirm the diagnosis, and allowing the use of the modified Duke criteria again helps you diagnose bacterial endocarditis or infective endocarditis accurately. So usually it's treated with penicillin, which is a beta-lactam antibiotic, because this mimics a component of the cell wall. Now, 2 foodborne diseases to be aware of, so just going to briefly touch on these. So the first one is Salmonella, which is a common bacterial disease that affects the intestinal tract, and it lives in animals and human intestines, and it's shared through feces. So humans normally become infected through contaminated water or food, and usually it's through meat and eggs that we become infected. It causes gastroenteritis in 2 ways. So the bacteria in itself secretes proteins that alter host cell function and structure via type 3 secretory systems, which act like a needle and syringe mechanism to inject toxins into our host cells. But also our host innate immune system responds to the bacterium by recognizing those repeated features that it detects on bacterium, such as flagella and lipopolysaccharides, and the toll-like receptors recognize these, and therefore we initiate our inflammatory response and attract phagocytes and so on, and cause an immune response. One thing to be aware of is Salmonella has adaptations in order to allow it to get to the ileum, and these are covered here in this box. Another foodborne disease that we covered is Campylobacter, which is the most common cause of food poisoning in the UK. It's usually found on raw and undercooked meats, particularly poultry, and unpasteurized milk and untreated water causes as well. It can be split into 2 species, so Campylobacter jejuni and coli, and it's a gram-negative bacteria that are spiral rods. So the complications can be at the time of infection or post-infection complications, and post-infection complications include arthritis and Guillain-Barré syndrome, so effects on the central nervous system. And the symptoms of Campylobacter normally last anywhere between 1 and 10 days, with the incubation period being 2 to 5 days. Again, it's adapted to allow them to survive in our system, and chicken is the main source of infection, causing around 50 to 70% of Campylobacter infections in the UK. And our controls for Salmonella are less successful for Campylobacter, which is why it's the biggest cause of food poisoning in the UK. Lastly, for this video, we're covering anaphylaxis. So anaphylaxis is a word that means simply a serious allergic reaction that occurs very quickly and also can cause death. It can affect the whole body, often within minutes, in response to the substance that you've been exposed to, the allergen, but sometimes it can also occur after hours. It can cause skin rashes, itching and hives. It can cause swelling of the lips, tongue and throat. It can cause systemic problems, so shortness of breath due to bronchoconstriction. It can cause chest pain and low blood pressure due to vasodilation. So how do these happen? It can happen for a variety of reasons. So foods can cause anaphylaxis, such as peanuts, tree nuts, sesames, fish, shellfish, dairy products and eggs. Or non-food products can also cause it, so latex particularly is a big one in hospitals, penicillin as well, and other drugs can also cause anaphylaxis. So the symptoms very briefly explained: vasodilation occurs because histamine releases nitric oxide, which is a potent vasodilator, and bronchoconstriction occurs because histamine binds to H1 receptors. There's also more pathophysiology behind bronchoconstriction in the release of leukotrienes, and as well edema is caused by the blood vessels being dilated, permeability of the blood vessel walls, and therefore fluid leaks out to the tissues. Very directly, you can link treatment to the symptoms, so you want to block these things happening, so vasodilation and bronchoconstriction. You can do this with antihistamines. You can reduce the inflammation with corticosteroids, and again you can give adrenaline, which causes vasoconstriction and increases that blood pressure. So one thing important to bear in mind is that antihistamines alone will not stop anaphylaxis. It's just the first line, because the first line treatment is actually adrenaline or epinephrine, and antihistamines should be given as well as those. So that's everything for this video. If you do have any feedback, please feel free to email me or leave a message below. Any feedback is greatly received, and I hope you found the video useful. Thank you.